Hi everybody, Dr. Smith here. Today we'd like to do a deep dive in some cardiac conduction issues and also go over the EKG. Specifically, we'd like to talk about tracing segments and the conduction cycle as well as torsades. So let's go over the basics. So first off, what is an EKG? It's a tracing of the heart's electrical activity along 12 paths or leads. It has multiple uses. It is used to detect arrhythmias, infarctions, or heart attacks, physical damage like with trauma, drug toxicities, many uses in medicine. So let's go over the normal conduction system. How does the heart's electrical activity actually move through the heart? Well, the impulse is generated in the SA node, then goes through the internodal tracts down to the AV node, through the bundle of His, through the bundle branches, and into the Purkinje fibers, ultimately into the heart muscle itself. So let's start with the SA node, or the sinoatrial node. This is the intrinsic pacemaker of the heart. This is what sets your heart rate. It is located in the atrial wall, just below the superior vena cava, up near the top of the heart. It actually activates the atria to contract both the left and the right atria. Next, the signal goes through the internodal pathway to the AV node. Now, the AV node is used to slow the conduction from the atria to the ventricles. This allows the time for the heart for the atria to contract, to completely empty, and for the ventricles to fill up. The key point is you want this delay here to slow down the heart rate, otherwise you'll be running at 200 to 300 beats per minute. After the AV node, the cardiac conduction enters the ventricles. This is where things start to speed up significantly. It first enters the bundle of His, then it goes through the left and right bundle branches, finally into the Purkinje fibers. This is wanted to be very fast, so the Purkinje fibers do their depolarization very quickly to help the entire ventricle depolarize at the same time. Of note, for normal depolarization, it actually happens from right to left, so that's one of the things that gives us our normal morphology on EKG. And as we said, the last in the chain of the electrical system is the Purkinje fibers. These are located all over the ventricles and allow the entire muscle mass to contract at almost the exact same time. This allows you to empty both ventricles simultaneously. So on this slide, we're looking at diagrams that show the lead placement. So these show the general axes and the placements along the body and how we start to go from these directional electrical impulses to the 12-lead EKG that we get. First, let's talk about the precordial leads. These are V1 through V6, and they look at the heart from an anterior to lateral position. We also talk about some other augmented leads, such as V7, 8, and 9, and those are more posterior, but again, they're in the same plane looking at the backside of the heart. And this is a list of the 6 limb leads. Obviously, these are placed on the limbs, and in conjunction with the precordial leads, they allow us to get all 12 tracings of your standard EKG. So when we're talking about the EKG and the regions of the heart that it measures, we're actually looking at specific physical portions of the heart, and these are very important, especially when somebody has a myocardial infarction or heart attack. So these are the classic distributions of your EKG, such as 2, 3, and AVF being an inferior MI. So this is that same information, but drawn out on EKG. Now you can kind of see how different morphologies lead to different parts of the heart on a 12-lead EKG. So that was a brief review of the EKG. Let's go into the waveforms, which is really what we want to talk about today. So let's go over some pink paper basics. What do we actually see on EKG tracing? So the y-axis is voltage and the x-axis is time. Each small box along the x-axis represents 40 milliseconds. 5 small boxes makes 200 milliseconds or 0.2 seconds. The vertical boxes are voltage, with each one being 0.1 millivolts, so one large box is 0.5 millivolts. So let's transition to intervals and segments. So notice that there is a difference between an interval and a segment. A segment connects 2 waves without including the waveform. However, an interval is the segment plus the wave. This comes down to, it's really important when we talk about specific disease states. However, for us, in general, you just usually want to talk about the intervals. So let's review the EKG tracings. The P wave represents atrial depolarization. The PR segment is where the electricity slows down through the AV node and allows the heart time to fill up the ventricles. The QRS complex represents ventricular depolarization or contraction. The J point is where the QRS meets the ST segment. The ST segment is between ventricular depolarization and repolarization, or contraction and resetting. The T wave represents ventricular repolarization or ventricular resetting. The QT interval is the time for one complete ventricular cycle, so the depolarization and repolarization, or ventricular contraction to relaxation to resetting for the next cycle. So first, let's take a look at the P wave. This represents atrial contraction or depolarization and is normally 0.1 milliseconds wide. Why do we not see it when it's being reset? Well, it's actually buried in the QRS complex. If you were able to take out the ventricles, you could see it resetting, but we just don't. In general, the repolarization happens from left to right and top to bottom, so therefore the net vector or the net direction of electrical activity is down to the left. So in the EKG, you expect it to be positive in leads 1, 2 in AVF, and negative in AVR. The PR interval again represents the delay in the AV node and is normally from 0.12 to 0.2 seconds or 3 to 5 small boxes. The QRS complex represents the ventricles contracting or depolarizing. There are variable morphologies depending on where you're measuring, such as a limb lead versus a precordial lead. Again, there's a lot of muscle mass in the ventricles, which means a lot of voltage, which is why you have a higher voltage on the paper. As your heart gets larger, say from age or from chronic high blood pressure, that's when we see even higher voltages on the EKG. The ST segment represents the time between ventricular repolarization and depolarization, or contraction relaxation. This segment should be flat because the heart is overall electrically neutral. It is resetting, but it's not transmitting any electricity from one portion to the other. You may have a gentle upslope, and some people have natural variances in their EKGs. The T waves represent ventricular repolarization or relaxation resetting. Normally the T wave is 0.5 to 1 millivolt, and it should be in the same direction as a QRS complex. So if your QRS is upright, you expect your T wave to be upright since the contraction and relaxation happen in the same general direction electrically. Now importantly is the QT interval that we would like to talk about today. So the QT interval is the total duration of ventricular depolarization repolarization, or one full cardiac cycle for the ventricles. It lasts from the beginning of the Q wave to the end of the T wave. The length varies and is dependent on many things such as heart rate, age, medications. In general, it is about 440 milliseconds or less than 50% of the RR interval, or the top of the R wave to the top of the R wave of 2 prior beats. The QT wave is inversely proportional to the heart rate. So that means as the heart rate goes up, the QT interval should go down. As the interval increases in length, there is an increased risk of torsades, which we'll talk about shortly. So why do we care about the QT interval? Well, let's talk about what happens when it gets too long, or prolonged QT. Normally, men have a QT interval of less than 440 milliseconds, and women have a QT interval of less than 460 milliseconds. We actually have to correct for this. If you go for a jog and your heart rate gets elevated, your QT will naturally adjust for your heart rate, like we said earlier. There are multiple formulas to do this. I've included one that's very commonly used in the PowerPoint. However, in general, they all have about the same accuracy, and so the QTC that you read on the top of your EKG is always very accurate. So what prolongs the QT interval? Well, it seems like everything. Many medications that we administer can, including Zofran. Lee et al. Did a study that actually showed that on average, Zofran increased the QTC by 16.2 milliseconds after getting a single dose of IV Zofran 4 milligrams. So prolonged QT is very important for our patient care. As we discussed, Zofran can prolong QT syndrome, so we need to be very careful when we're administering that for nausea and vomiting. Always ask your patients if they have any history of prolonged QT syndrome or history of cardiac arrhythmias with medications. Additionally, if you have an EKG, make sure that the QT is less than 500 milliseconds before you give Zofran. How does the QT becoming longer actually cause torsades or other arrhythmias? Well, let's look at the normal cardiac contraction. So during a normal heart cycle, we actually have a plateau phase where the heart is stuck in a phase where there can be no more signals transmitted. This allows the heart to have time to complete its cycle and reset before having an early signal or early firing. There's an absolute refractory period where nothing will get through no matter what, no matter how hard you try to get the heart to contract, it will not contract. However, what we're worried about is the relative refractory period. As the heart begins to reset before it's ready, there is a small amount of time where a strong enough signal can come in and cause the heart to contract early. If you take a look at the two images in the middle, you can see the black is a normal cardiac cycle and the orange is what happens when the QT is prolonged. As the QT gets prolonged, it increases the plateau phase and thus increases the relative refractory period. Ignore the channels listed in here. They're very important for cardiac induction, but this is why sodium, potassium, and calcium are important for the heart. However, we're looking at the timing here. So as that orange bar gets longer, or the relative refractory period gets longer, or the QT gets longer, there's a higher chance of another signal coming in early and causing the heart to abnormally fire early. When a new action potential hits this prolonged relative refractory period when the QT is longer than normal, this is called an early after depolarization. This causes the heart to contract abnormally early and can even lead to a sustained arrhythmia if it keeps propagating itself and hitting the early after depolarization period. If it propagates exponentially, this leads to torsades or other arrhythmias. And final, we'd like to go ahead and just remind you the torsades treatment. If your patient has stable torsades, give 2 grams of magnesium sulfate IV over 10 minutes. Check out the Pinellas County EMS Medical Operations Manual C5 for that. Unstable, defibrillate immediately, unsynchronize at 150 joules.